Welcome to the Birth Squad podcast. If you're riding with the squad,
hey fam,
and if you're new,
welcome to the squad. We're your hosts, Dr. Ijama Okwando and Dr. Kanisha Thomas. We're two licensed obstetrician and gynecologists, as well as best friends.
The Birth Squad is a podcast for birthing individuals by two Black female physicians who use stories from real women to educate about pregnancy, birth experiences, reproductive health, and all things in between.
And while we hope that you love learning from our podcast, it is not intended to be a substitute for medical advice, diagnosis, or treatment. So please consult your healthcare provider for your specific care. And to learn more about us and about the podcast, please follow us on Instagram at The Birth Squad. And also check out our website, thebirthsquad.com.
Please keep in mind that some of our episodes may cover topics that could be triggering to some individuals. Listener discretion is advised. Meet Dr. Jess Daigle. She's the next badass birth warrior who will share her story to help the squad navigate through the complex and inspiring journey of pregnancy, labor, birth, and motherhood. In this episode, we are talking about what it means to have a premature infant and the neonatal ICU. During the interview, you may notice some medical terms or jargon, but don't worry, we got you. We have included definitions and explanations in the episode description. So please listen up and enjoy her story.
Hello and welcome back, everyone, to our next episode of the Birth Squad. Today we have an amazing guest, Dr. Jess Daigle. She is a NICU specialist, which she will explain, and she helps NICU mothers navigate through their journey through education and also providing one-on-one coaching. So welcome, Dr. Daigle.
Thank you. Thank you so much for having me.
Yes, thank you for joining us. Do you mind just starting by introducing yourself and sharing a little bit about your background?
Okay. Yes. Thank you so much. So I'm Dr. Jess Daigle, actually Jessica Daigle, but I go by Dr. Jess. I'm a board certified pediatrician and a neonatal pediatric hospitalist. And I'm also the founder and CEO of A Mom and Me MD, which is an Atlanta-based concierge practice and also a life coaching business designed to help NICU families who transition home from the NICU through actual in-home care and education, but also I've built in life coaching as well to help moms who are trying to get back on track after having a NICU experience.
Thank you so much for that. Can you tell us what led you to pursue a career in neonatal care?
Yeah, so actually from young, it was the whole reason I wanted to be a doctor. So I grew up wanting to be a neonatologist, which is a pediatrician who specializes in newborns who are sick. And so that was about at the age of 10, actually. I had read this book by this family called The Long Dying of Baby Andrew. And this family was dealing with having a preemie baby. And around that time, a lot was changing in medicine with regard to how we could care for preterm infants, like they were able to live longer due to something called surfactant, which helps the lungs mature. For those who may be listening and not doctors, but but this family really wanted their baby to be able to die with dignity and not have all what they considered was heroics. Like they thought their baby was basically being treated like a guinea pig as opposed to being able to have the right to choose. Like, well, we don't necessarily want them to have to suffer and things like that. So I was very intrigued by that because I just always liked babies anyway. And then I was like, well, I want to save the preemie babies. So I did some research. There's this website called Neonatology on the web. And this many years later, it's still a website. So it tells you what to do. Like if you want to be a neonatologist, you got to go to school, you got to do this all the way up to fellowship. And so I was like, all right, this is what I'm going to do then. So I went all the way through, made it to my pediatric residency. And then my intern year, I had a miscarriage. And so that really changed the trajectory of my life in a sense of my awareness about things that patients go through. It was the first time I remember feeling like a statistic, which I find so interesting. As Black women, we can we're already full of statistics with a lot of things, right? But I never really just thought about that was even possible for me, even though I knew it was possible, being in this work. And so after that, I got pregnant again. like because that was in 2012. Like in 2013, I was pregnant again earlier in the year. And because of that, I was considered high risk. And so I was seeing like a maternal fetal medicine doctor, and I was doing the progesterone shots. And before I had my miscarriage, my OB had wanted me to be on bed rest, but I did it at my house. And I was like, I mean, I hope I'm bed resting the way she wants me to, like I didn't really feel like I was doing anything strenuous, but I wasn't just like sitting down all day, I would just kind of walk around my house, or I might still go get something to eat in the evenings with my husband. And so I dealt with a lot of guilt around that. So the second time when I got pregnant and she was like, yeah, you're starting to have that cervical funneling again. I was around 21, 22 weeks. I was like, if you're going to put me on bed rest, sister, I got to be in the hospital. So I actually got admitted to Grady here in Atlanta, and I was there for 65 days on bed rest.
Dr. Jess mentions a few things right off the bat. One of them is what we talked about in another episode, also named Jess, in season 1, episode 8, about miscarriages. As we mentioned in Jess's story, this unfortunately occurs in 1 in 4 women.
Dr. Daigle fortunately was able to conceive again and mentions cervical funneling, which is also known as cervical insufficiency. And she mentions progesterone shots. So let's break this down for you.
Okay, well, cervical insufficiency is when the cervix shortens during pregnancy. We don't always know why this happens, but some women are at increased risk if they've had trauma or surgery to their cervix, such as a LEAP procedure.
Exactly. And data shows us that using progesterone can help prevent shortening of the cervix, premature rupture of membranes, or preterm birth, which is what happened in Jess's case.
Now, during pregnancy, if we notice that your cervix is still shortening despite the intervention of progesterone, we may recommend a procedure called a cerclage. Now, what is a cerclage, you wonder?
Well, a cerclage is when we stitch the cervix close. Typically, these are placed before 24 weeks and removed around 36 to 37 weeks. Okay, let's get back to Jess.
So I stayed there the whole time. And like every Monday I cried. And I was like, oh, it's like another week. But I was grateful because I was still pregnant, but it was just a lot, like feeling like your life was on hold. I was getting towards the end of my second year in residency. I actually had been interviewing for fellowship on bed rest for neonatology fellowship. So then it was Skype. So I was Skyping interviews because I made it to one interview out in California with CHLA. And then that was the last one I could do. She was like, no, ma'am, no more. And any other interviews, you have to do it virtual somehow. So that's how I did it. So anyway, through all that, I ended up getting, in matching and things like that. But my son ended up being born at 31 weeks. And so he was in the NICU about 5 weeks. And so dealing with all of that, like it just became real for me what families go through. And so I say I got the best of both worlds in the sense of I understand the struggles that families endure. And I think it just made me a better doctor, like real understanding as opposed to just being like, I know this is hard because that's the thing to say. It's like, no, I know this is hard, And so I just took that on and started working with families in the hospital, like backtracking a little bit because of the time in the hospital. And also after coming home, he had to go back on the feeding tube for a little bit and just a lot of things with that. I ended up finishing my training late, like about 4 or 5 months later. And so I started fellowship later, and I wasn't really like thriving up there. I was in Baltimore, and my son was with my husband in Louisiana and my family. And so, I tell people now, like the moms now, and you'll see in some of my posts, like I tried to compartmentalize the experience. Like, hey, I'll put my preemie baby over here, and like my life goals are over here, and like they don't have to intersect, but that's not real life. Like when you have a child, it does impact everything about your life. um, and so when I came to that realization that I was going to need to like really choose, like to be authentic in the fact that I wanted to be there with my son and not everywhere else, and like feeling guilty that I'm like saving everybody else's baby and my son is like somewhere else. So I resigned from fellowship and I ended up getting a job here in Atlanta with level 2 NICU, which worked out perfectly because I'd had enough of the training and skills to be able to do that job pretty well. And so that's what I did up until like 2022 actually, and now I just travel as I started building this business. But that is what I was able to do, and how my life has kind of pivoted from those experiences.
It just sounds very challenging, one, to be going through and pursuing this roadmap that you went through to get to your goal, and then also experiencing the very thing that your patients that you're going to serve one day. Can you tell us a little bit more about, your birth experience and then like the initial NICU experience?
Being in the hospital, I had a couple of scares. Like, so around 24 weeks, my OB gave me my first dose of like steroids. She was basically 24 weeks is when she's like, okay, we're at least viable. So if anything happens now, we have a good chance. So I got a dose then. So I think, I think right around then I started having a little bit of like the early symptoms. They would send me over to labor and delivery. I would get fluids. They watch me, and then I go back to the floor. Going up in a little bit past 28 weeks, she gave me another dose, and she was like, okay, like, we'll just kind of stop here. Because your chances are a lot better. And again, that was like the second time I started having a little bit of like some early contractions, and so they did the same thing, gave me fluids and watched. Then I ruptured, and I was like, oh no. But so she put me on antibiotics, and then we just watched because I didn't like dilate. It wasn't dilating necessarily, but I had ruptured. And thank God I like made it. And so then that third time, I told her, I said, oh no, this is real labor. Like, we're having this baby today. And it was interesting in the sense of taking in the moment of what was really happening. Like, a lot of times you have the doubt, like you think every little thing, you start trying to figure out, was that the reason? Was that the reason? Like, that I had the miscarriage, or was that the reason I went early? And I knew I was doing my best. Um, but when it came time to actually having the baby, when she came in, it was residents there too, but she was actually there for that part of it, which I was happy, because with my miscarriage, she didn't make it. And the way that whole situation went, it kind of had rubbed me the wrong way. And my husband was actually mad that I went back to her as a OB, but I was like, she's a good doctor. I think it was just a teachable moment, I think. And that's one of the things I've learned, is like, you have to learn how to separate like a incident or a decision from like a person's character. I was like, well, I had to look at the whole character of her as a person, how she's been the whole time I was pregnant, all the time I had concerns, versus this one thing. And I think it just made me more aware of like all the pieces that have to go together well in your experience. Like, it's not just the doctor and the patient, is like nursing staff, is techs. It's all, so many people are involved in the process, and the cohesion and teamwork of that matters, and the communication especially. But for my son's delivery, it actually went quite well. I think I would labored for maybe 8 hours, but as far as that went, it was actually as beautiful of experience as I think it could have been, given the circumstances. Like, I delivered him. I knew he was going to go to the NICU, so I didn't have any hesitation about that. So I think that's the benefit of already being a doctor, even being a pediatric resident and going into NICU. It's like I already knew what to expect with that regard. He got a dose of surfactant. He was on the vent for just that night. And then the rest of the time, he was on air the whole time he was in the NICU. He got treated for jaundice, for being a preemie, feed a grower type energy. He did really good in the NICU. He was like a rock star in the NICU. So that's why when he came home and he was having some aspiration type symptoms, I was like, dude, like, what are you doing? You didn't even do none of this in the NICU. So again, I count it all towards experience of understanding the struggles that my patients go through. So I'm not as upset or aggravated about it. And it's interesting, he's doing so well now. So it always makes you wonder, if the outcome had been different, what your feelings would be. But I think you can only take what you can from your experience as it is. So that was like the part about the experience for me, is I tried to be very authentic in my feelings about it. If I was frustrated, if I was cried, I didn't judge myself for any of it. Like, if I wanted to cry, like, this is real, like, this is hard, but I try to look for some good in the situation as well.
Wow, that was a difficult situation that Dr. Jess described. We wanted to take a moment to unpack some of her story.
Preterm birth, or rupture of membranes, which is your water breaking, is rare. This occurs in less than 1% and 3% of pregnancies, respectively.
In Dr. Jess's case, she was noted to have a short cervix and started on medication. Unfortunately, this did not really help her, so her doctor ultimately recommended a hospital admission for bed rest.
It's important to note that not everyone will need to be admitted to the hospital, so please talk to your provider if you have questions.
While being admitted, Dr. Jess started to have contractions. Then her water broke, and then she went into labor. Now, in general, if you are less than 34 weeks and your water breaks, we try to keep you pregnant as long as we can until you get to 34 weeks. However, most women whose water breaks will remain pregnant on average for only a week later.
Additionally, prolonging pregnancy, while helpful for the baby, can increase risk for mom. Specifically, it can increase the risk for infection, bleeding, and in some cases, the need for a C section.
So it really is a delicate balancing act where we're trying to balance the health and the safety of the mom with that of the baby as well.
And in Jess's case, she got steroids to help with the baby's lung development. Other cases, we may also give you magnesium, which is a medicine to help with infants' brain development if your child is less than 32 weeks. Okay, let's hear more of what Jess has to say. I think you talked about a lot of things that your training helped influence your personal experience. And you said a lot of the buzzwords that we think about as providers. For people who don't know, we work so hand in hand with the pediatricians and the neonatologists. And you said, like the landmarks, right? 24 weeks is a huge milestone, right? With viability. 28 weeks, another huge milestone. Next one is 32 weeks that we really look at. So you had that knowledge, which on the one hand probably was really good. On the other hand, maybe it was a little scary. You're like, I know too much.
Yeah, yeah.
How has, the reverse, how has your experience, your personal experience, how does that influence how you interact with patients? Do you share your experience? Do you tell them certain things that will help them get through it? Like, what does that look like for you?
So one of the what I think is the best way I think it has informed my experience is the awareness of the fact that this is not just like some simple thing. Like for example, because I have a very big passion. Even before I had this experience, I was always very passionate about communication and bedside manners. Something I always paid attention to. I'm really big on validation. What it has made me aware of is that those little things that we think don't matter, like when I am getting ready to, like, say if someone's coming in, they're 25 weeks, I make sure I have a conversation with that family. Like I'm very intentional about it. If the OB hasn't called me, I go to them and say, hey, has anybody talked to this family about what to expect? And then I'm able to build on that. Like, hey, this is not what you expect. I know this is not what you expected. So let me tell you what to expect right now. And I'm going to tell you that we're going to have these conversations again. Like I laid that out too, because I think that's the other thing too. It's like sometimes we think we could just tell them stuff and then it's like, well, I already talked to them about that. Those people are not thinking about all the stuff you just told them. I mean, they probably take like 10% of what you've said, and it's just made me more patient as well with people. Like when I go to tell them about their baby, like needing to stay in the NICU, and they're asking me about the circumcision, like the nurses would laugh at that. And, before that, I'd probably be like, that's interesting. But I understand now that it's not that they just really care about a circumcision. It's what they can hold on to. It's what they can understand. It's the one thing they did plan for, right? They knew what they felt about that. They was like, yeah, I knew I was going to consent for this and this and this, but I don't know nothing about getting this surfactant, or do I have to give you permission to intubate my baby for this? Or do you just decide to, like, all these things, right? These people are not thinking about that kind of stuff. And it's why even right now I'm doing a master class next week for that, because the surprise that is on people's faces when you tell them their baby needs to NICU is really just informed how I interact in terms of I'm more curious, I'm asking more questions, I'm really trying to see what is it that they need from me then and what they might need from me tomorrow and next week, and just being very open about that.
We're on the medical side, and we know a lot of things. But at the end of the day, we're asking people who haven't prepared for a situation like this to all of a sudden be able to make a huge decision about the life of their baby, their loved one, and not quite yet understanding the medical stuff that we went through training for. So I can imagine, and I see it myself as an OB, the overwhelming amount of information that the patients get, the number of
Yeah.
people that they're seeing in just a day might be up to 100, really, if we count every single person. So for you who was on the other side, is there any tips that you have for, a patient, their family member who now unexpectedly is having a child in the NICU, um, probably is going to have to be there in the hospital more or coming back and forth to the hospital more than they were anticipating? Any resources or things that they can do to prepare themselves?
Yeah, yeah. So I think the first thing to do is I would recommend they get some kind of notebook or have some kind of system for documentation. And I let people might laugh when you say this, but it's so much coming at you that terms that people are using, advice they're giving you about when you can visit, what care times is. There's so much language. It's like a different world, right, for them. So first, like having like a way to keep track of some information, and then they can go to websites like Market Your Dimes. There are organizations like Hand to Hold. There are a lot more I see popping up even since I started doing this work, because these were only knew about March of Dimes just because of the fact, like I said, that I wanted to go in it. But I've even learned more about other organizations that support families. And so now that we have the internet, is so much different. So it's good and bad because you can get like some overwhelming information. So I would recommend having a book, and then don't be afraid to advocate for yourself and ask clarifying questions. Sometimes patients are afraid to say, I don't really understand what you mean by that. Can you explain it differently? I try to be aware of that already. So I use a lot of analogies that are like visual. And sometimes I'll ask them, are you a visual learner? Like, do you like pictures or do you like to read stuff? I ask them. And so, like, if they want me to print something and then I say, review it and we can talk about it tomorrow. And some patients will be like, yeah, I read this and this and that. And it depends on where in their journey. Really be okay with advocating for yourself. I think that's the biggest thing. So, first, when you hopefully, and I'm learning so much that we are failing parents a lot in this way. I'm in this group with like 30 some thousand NICU families, and I hear so many stories of things that I would not like. I'm kind of appalled by actually. I'm like, oh my God. And so I'm like, now I'm on this tip on educating medical staff about like, and families coming to the NICU, you should already have some things in place. This is not our first rodeo, even though it might be theirs, right? So we should be able to have like some type of welcome, like, and not a welcome, like you're just excited for them to be there, but just something where they understand the lay of the land. Like, hey, this is the NICU. This is where you come. This is what you can expect to see here. This is who can help you if you need help with this. This is when the doctor rounds, just like so they understand the flow of the unit. And so that's why having that little notebook and stuff can help too. So you can keep track, like you said, you see so many people. Okay, I met the social worker. Like, what's your name? Okay, this was the doctor that rounded today. This was the plan of what they said. So I always start off with what the baby needs to do to go home, because that's pretty much the same for everybody. And with some outliers, like, okay, your baby needs to be able to eat to go home, but that could require a tube. Or, we like for you not to be off oxygen, but some babies do end up needing a trach or other things. And so you just give those caveats when they're needed. But overall, being able to eat, breathe on their own, gain weight, grow, not need further medical care in the hospital is the criteria for going home. And so just helping them to understand that globally allows them to understand like where they are now and where they're trying to get to. And it's different because they're not postpartum at home with the baby, so they almost have an extended postpartum. Like, it's like it really lasts the length of the time their baby's in the NICU, and then they still have to deal with the same type of stuff when they come home. And even if not necessarily they're physically healing, depending on how long the baby's in the NICU, they're dealing with some new mental challenges, right? Because you had the one when your baby's in the NICU, you're dealing with guilt, blame, concern, fear. Then they're home, you're like, can I really do this? Oh, now I'm afraid because I had everybody on my team and now I'm by myself, and trying to find out all the therapists that they got to see and Does my pediatrician really feel comfortable taking care of a preemie that's been in the hospital for 100 days? And, just things like that. So I'm on a mission to increase our awareness in the medical community of what these families are really dealing with. So,
I wanted to touch on something that you mentioned about that postpartum period and how they're going to continue to be postpartum while their baby's there and how that transition is really hard. Can you kind of talk about that? Like, what are some things that these family members can do to help with that transition, help with discharge, and maybe even touch a little bit about early intervention? Is that one of the things you mentioned?
yes, so I can talk about all of it. So I think the first thing is the parents themselves realizing that it's okay that they're like scared, afraid, frustrated, mad. Having a baby in the NICU is almost like a grieving process as well. So the stages of grief as well, like denial, then like anger, then you're bargaining. You're trying to like, okay, well, Lord, if you just let my baby come home okay, and just all the things, then depression, and then acceptance. And I posted about this, and I have a Facebook group, and me and one of the moms was talking, and she was like, "It's interesting. So I wonder, like, if the length of time affects like how you cycle through those phases." And I was like, probably so, right? If somebody's there for like 3 days, not to diminish the fact that the baby went to NICU, because that's still traumatic in a sense if you didn't get to do your skin to skin. Just the whole fact that it didn't go the way you planned is something that people have to kind of manage and deal with emotionally, mentally. But it may not take as long as because you were able to have your baby there now that you see within a short period of time. But those families who are like 6 months out and they're still having to find rides to the NICU and get milk, or they've had to return to work, I just really do think it's a different experience. And I think we honor everyone's experiences for sure. Um, but really, them first accepting that they also are going through physical transitions and need to provide themselves grace in that regard, that their body also is still healing. And sometimes that's why I'm really big on is we shouldn't have to give people permission. But I think in those cases, understanding that the emotions are layered, that's why I'm very intentional about saying, hey, it's okay if you go home and take a shower or go home and visit your 5-year-old, take them get some ice cream and come back. We got you. We'll call you if there's anything. What's your best number? I think it's just sometimes saying that and let them know it's not because I don't want you sitting here, but I see your struggle and I know you care about the 5-year-old that's at home that's missing mama too. And I think also it's interesting about the family members when you bring that up, because some people are very, very private about their babies being in the NICU. And I don't know if it's like a shame thing or what. I talk to so many families and they'll be like, yeah, I didn't even tell my, I didn't tell my family my baby was. And I'm like, well, when are you going to tell them? Like, they know you've had a baby. The NICU parent doesn't ask for help because they feel like they're burdening. And then the family member doesn't want to impose, like they don't want to feel like they're being nosy or putting pressure. So then nobody gets help. There's that separation because everybody's waiting on the other person to like extend the olive branch, so to speak. And so what I would say to the family members is to don't come with empty platitudes of like, I understand. You don't understand if you haven't been through it. It really, because I didn't, as much as I wanted to do the work before I had a premature, I still didn't understand. I knew the medicine, like to your point, John, but like I knew what it took to take care of a preemie baby, like in the hospital. Then nothing, no clue about what the struggles were, leaving your baby every day to go home when you wanted to put them at the breast, but you got a pump and then your breast hurt and then you just kind of want to give up, but then you don't want to look like the person that's not giving their baby the best milk. It's so many thoughts that go through these families' heads. So it's more to say like, this is hard and how can I support you? And sometimes it's even just saying, hey, I know you've got to pick up your kids from school. Do you want me to grab them this week? Like give some examples, but then just still check in, like let them know you really are there, and let them kind of come make their way towards you too. It's kind of a little bit of a little back and forth, I think. Sometimes it's that awkward, you want to say the right thing. You may say something that just ends up actually hurting them in the wrong run. And I think we have to be okay with silence and be okay with saying, this sucks. and let me know how I can help you. And that being it, you don't have to have a monologue all the time and all these extra things. So it's just really letting them know that you hate this for them. Like, you may not understand it, but you don't like that they are having to go through this, and just being that honest about it. Then and so then the family members, the people going through it, I do encourage that they connect with their OBs about depression. There's a postpartum support international organization that you can call anonymously, because I know that's the thing too. At least I feel like with mental health, we're starting to see people become more comfortable about it now. Like, so I see more posts about people owning that they're taking care of their mental health. So I'm hoping that that continues. So that way, even in the NICU family side, connecting them with a counselor. I think that they should, even if we don't have one on site or something, even having our own list of referral sources to say, hey, this here's some people, and then checking back in like a week or so. Hey, have you reached out to anyone? Because again, they're worried about so much. We almost need somebody to be worried about them, just like with the whole fourth trimester care postpartum. They're saying mothers need mothering. It's the same way for these NICU moms. They need someone to kind of be like their mother in a sense and look out for them. And then transition into the discharge home is more of that same thing. So hopefully they've been keeping track of the medical issues, like what the diseases are, what was the treatment plan and resolution, and really getting clear on that. And like what is going to be needed, continue follow up and being very clear on that. Again, some places do it better than others, in terms of really helping families outline it. But I love to empower families. Hey, this is your child. You have the right to know everything that concerns your child. If you don't understand, ask for clarification, maybe do a little bit of your own research. And there's a way to talk with physicians. I tell people, just come and say, it's like how I feel like when we were residents and you wanted to ask your attending something, but you almost had to pre-read a little bit. Like, I was reading this, and so I have this question. Like, it's a way to approach them to like, hey, I'm trying to understand a little bit more about this vent or this trach or this. Like, what are the next steps? And just being very clear like that. No attitude needed either way, right? Just factual information. And then connecting with your doctor and just really putting yourself on a schedule. Like, this is when these appointments are. You kind of almost have to make you really organized in a sense. Like, I feel like these kind of experiences amps up your organization skills because it's a lot to keep track of. But just understanding that it's going to be a journey. And I think that's been a surprising part for some families too. Like, they think, because I actually had that fallacy. Like, I just get my baby home, that's it. And you see, he had to go back on the feeding tube, he had to go to speech therapy and all these things. And I felt kind of blindsided because he did pretty good in the NICU, actually. Like, they called him like super preemie. And so I really try to understand or relay the message to the families that it might be an extended journey. Like, the NICU experience does not necessarily end inside of the unit. There is a lot of growth and transitions that still need to happen when you go home. Most people who have had a preemie, and if they still have some medical needs when they come home, a lot of times can have physical therapy, speech therapy, occupational therapy. Folks come to the house and they'll do assessments and decide what kind of therapy you need and kind of help you get started. And some of the details can vary depending on insurance and all these things, like how long, but at least getting your baby a good jump start, a good head start, and what they need is so important. So I definitely encourage families. Like, I've had two preemies. So my son was 31 weeks and my daughter was 36 weeks. And so it's very interesting how opposite they were. Like, he was very verbal early, considering he was 31 weeks actually. Like, but my daughter her verbal was delayed. And so I put her in speech therapy. It never hurts to get an initial assessment. And it helped really inform me, because that's not, like, I tell patients, as doctors, we don't learn everybody's stuff. Like, I don't know nutrition to the degree that a nutritionist does, or I don't learn speech things the way the speech therapist does. I understand like the global understanding of what they can help with, but like in terms of what they do day to day, I didn't really have a good window until I took my own daughter, and then I was able to see things I could do at home with her to maximize her own therapy and growth. And so that's the other thing I think too, is sometimes family parents feel like the doctor is going to be the end all be all. It's like, no, you need a team. You needed a team in the hospital. You need a team when you go home of folks that's going to help you and your baby thrive.
What Dr. Jess said is so important. It takes a village, y'all. Our training does not cover everything, so please ask for resources to help you in the care of your infant.
One prime example of this is early intervention.
Now, Dr. Kamisha, what is early intervention?
Early childhood intervention is a support and educational system for very young children, usually under the age of 3, who show signs of developmental delays in areas such as communication, social or emotional, adaptive, or physical and motor development, including vision and hearing, or for children who are high risk. For example, if your child was premature, had a low birth weight, or experienced birth trauma.
Now, let's hear the rest of Dr. Jess's story.
So whenever a baby is born early, we have like the chronological age. So that's actually the days that they are alive, have been alive. And then the corrected age is you taking that age, like based on how, when they were due, and then you make an adjustment for the fact that they were early. The chronological age is the actual age and the number of days. And then the adjusted age accounts for the fact that they were early. So, and we use that for development. So if a baby is actually like 3 months old chronologically, but they were born 3 months early, they're almost like a newborn in what they should be doing developmentally. So if they were born at 28 weeks, which is roughly like 12 weeks early, at their 40 weeks gestation, they're going to act like a newborn, even though they're 3 months old, if that makes sense. And so when we use that when they're going to the pediatrician, so when we're looking at development, like you're like, wait, why is my 3 month old not social smiling and trying to like start to like roll or do something? Then we could say, well, they're gonna actually act like a newborn. So they'll just now be starting to be like alert and looking your face and things like that. But for people to understand it, really the adjustment has to do with understanding where they are developmentally. One of the things that families worry so much about is their baby's growth in terms of weight and how they're eating, and using those growth curves both ways helps us to like understanding where they would be now and what they would look like if they're corrected age, helps the families kind of just understand that they're actually on target.
When you look back on your experience, like look back on your pregnancy and postpartum experience, what advice, if you could go back in time, what advice would you give yourself?
I think that the most important thing that I would say is giving yourself like grace in the fact that you're going through it, and it's okay to like feel all of the things that you felt. I mentioned earlier that I tried to compartmentalize it. And so I wasn't accepting the fact that my life had changed and be okay with that pivot. And that's that acceptance part of like the grief. I think I would tell myself, like, you are going through something that, is not ideal. Even if you are making the best of it, it's still not something that if somebody's just said, hey, you have a term baby, I have a preterm baby. Like most of us, like knowing just in general what preemies have to endure, would pick a term baby, even though term babies can have issues too. But just if you're going off of generalities, that's what I would say. And so it's more like being like, Jess, like it's okay, it's gonna work out like in the end. But be okay that you have to change from like your original life plans, and like that doesn't mean anything about you. I think actually that is the best thing I can say, and what I would tell someone else. Having this experience doesn't mean anything about you personally. Because I think we internalize it, like even my husband was like, did I do something wrong, or did we do something wrong, or did we, like you trying to rationalize, like, is this a punishment? Like it's not a punishment, because just understanding that we all have a cross to bear is what I've kind of gotten from experience. And then just you can choose how you move forward in the experiences that you endure in your life. And I think that that's what has been empowering for me, is that once I realized like I can't go back and change that Liam was born early, but I can get on top of looking for resources for him. What can I do to better improve his experience at home, developmentally, reading, whatever? Then that's what I started looking for, ways that I could control things. And then that made me feel more empowered. And so that's what I would encourage a family to do. Like there's lots of things we're not going to be able to control, but control what you can, and then go on with the rest.
Mhm. Sound advice. Dr. Jess, you are so amazing. So I can't
Oh,
imagine
so are
that
you.
any family that has you and would be so blessed.
Oh,
Um,
thank you.
and I just would like you, if you would like to share a little bit more about your business, what you do, um,
Okay.
and then how our listeners can connect with you.
Okay, so I have two arms. So the Mom and Me MD is the concierge practice. So if someone's interested, they can go to my free meet and greet on my link tree on my Instagram, which is at Mom and Me underscore MD, and they would, sign, to meet with me and just tell me a little bit about their story, and then I review the package that I have, which is a 3 month package. That starts when the baby comes home, and I do like an initial assessment, reviewing all the discharge, the care in the NICU, and then work with them on a plan for optimizing their experience, their transition. The most recent family was it's a 27-weeker, but it was really feeling like they needed that extra support of someone who actually understood like the NICU experience and like their concerns about growth and feeding down to like the details. Because sometimes when you go to the part of the reason I started my business, it's because in traditional pediatrician offices, which is like it's so many it's a rush to see so many patients, and I just didn't like feeling like I had to like hurry up and talk to somebody in like 10 minutes when it takes like when somebody's really coming home, you really need a good 45 minutes to an hour to unpack some of the stuff that happened in NICU, what it means going forward. Like just even talking about the early intervention takes about 15 minutes, and so but then there's other concerns that they had, and sometimes they just need to like be able to process the experience because they've just been on go mode. Now they're home and they're like, oh, like what now, and still have questions about the baby, or will the baby really be okay? They're still worried about that. So I provide a lot of that one-on-one reassurance. I go to the home and see the baby at least 4 times. We do virtual check-ins because I don't just care about like what's going on with the baby. I check within the family. I do like the Edinburgh depression thing for the mom and the dad. We talk about, well, how is this impacting you? And I'm checking in with them weekly on that too. I really want to just be that person that they feel like they could pick up the phone and call. And then the life coaching it's probably more designed for moms who are kind of moving through the stages of grief that are now at okay, like I want to really focus on moving forward and not like stay kind of stuck in my NICU experience, because that's for me is what made the difference in my life. And so that's why I wanted to offer that, because like a lot of my clients have been, like my most recent one was a lawyer mom who was in the NICU, and she still had life goals. And I felt the same way, like going to fellowship and just even getting in the NICU, like you tend to think that this NICU experience has to define you in a negative way. Like that once this happens, that's it. Like you always have to just be under the weight of that experience. And I want families to feel free, like free to say this is a part of my life, but it doesn't define anything about who I am and what's possible for me or my baby. And so helping families see that too. So I'm on Instagram at mom and me underscore MD. And then on Facebook as my name, Jess Daigle. People come in my DMs. I do pay attention.
Well, thank you so much for joining the Birth Squad and for sharing all of your personal and professional knowledge. We really appreciate you.
Thank you. I love your podcast too. And I just love how fun you guys are and smart too and gorgeous. Look at that. Ticking all the boxes.
Well, thank you.
Okay. Thank you. Bye-bye.
That's the wrap of this episode of The Birth Squad.
Thank you so much for joining us this week. We are going to continue sharing stories from more badass birth warriors, because at the end of the day, you are the experts of your experience, and we want to highlight you and your bold, brave, and beautiful journey to motherhood.
And we want to hear from you. Tell us about what topics you'd like to hear more about. Hit us up on Instagram at The Birth Squad, and check out our website, thebirthsquad.com.
Most importantly, be sure to share this episode with your squad.
Until next time, I'm Dr. Ijama Okwandu.
And I'm Dr. Kamisha Thomas.
Peace, love, and solidarity from the Birth Squad.